Occupational English Test. Listening Test. This test has 3 parts. In each part, you'll hear a number of different extracts. At the start of each extract, you'll hear this sound. You'll have time to read the questions before you hear each extract, and you'll hear each extract once only. Complete your answers as you listen. At the end of the test, you'll have 2 minutes to check your answers. Part A. In this part of the test, you'll hear 2 different extracts. In each extract, a health professional is talking to a patient. For questions 1 to 24, complete the notes with information that you hear. Now, look at the notes for Extract 1. Extract 1, questions 1 to 12. For questions 1 to 12, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
Doctor, I appreciate you seeing me today. As you know, I've been managing multiple conditions over the years, and I think we're at a critical point with some of them, particularly my knee issues and my kidney function. Lately, my knee pain has worsened, which has really been limiting my mobility and affecting my daily activities. I've tried various treatments, but none have provided long-term relief.
I understand your concerns. Let's go over each of your issues systematically, starting with your knee. I see that you're scheduled for a knee replacement. How have you been preparing for this?
Well, I've been trying to keep active within limits, but it's been tough. The pain is more persistent now, and it's affecting even simple activities like walking around the house. I've been adhering to the medication regimen you prescribed, hoping to manage the pain until the surgery.
It's good to hear you're staying active. Now, regarding your kidney function, I see from your last results that there's been a slight increase in your creatinine levels and a decrease in your eGFR since last year. Can you tell me more about how you're managing your medications, especially indomethacin?
That has been a bit of a concern for me. I know indomethacin helps with my gout flare-ups, but I also understand it could be affecting my kidneys. I've been trying to use it sparingly, only when the gout pain becomes unbearable. It's a tough balance, trying to manage the pain while not making my kidney situation worse.
That's a prudent approach. Managing these medications carefully is key, especially given your chronic conditions. How about your blood pressure and other symptoms?
My blood pressure has been stable, thankfully, but there have been a few times when it spiked, and I felt quite uneasy. These episodes usually happen when I'm in a lot of pain or stressed. As for my asthma, it's been manageable with albuterol and steroids.
Good. Managing stress and keeping your blood pressure stable are vital. Now, let's discuss your thyroid function and how that's been since your partial thyroidectomy.
The Synthroid seems to be working well for me. My TSH levels have been stable, and I haven't noticed any major issues there. It's really the knee pain and the kidney function that are most troubling to me right now.
I understand. Let's summarize the clinical data from your tests and outline the next steps. Your creatinine is at 1.9 milligrams per deciliter, which is slightly up from last year. Your eGFR is at 45 milliliter per min, 1.73 mg/, indicating that we need to keep a close watch on your kidney function. Your uric acid levels are stable at 7.2 milligrams per liter, which is good news in terms of your gout management.
Yes, I've noticed those figures. What should we be looking at next?
Here's the plan. We need to continue with your current medications, but adjust your indomethacin usage based on your lab results. We'll conduct a CBC, kidney function tests, uric acid levels, and thyroid function tests today. These results will help us better understand how to proceed, especially with your upcoming knee surgery.
That sounds thorough. What about my mobility issues and the pain management until the surgery?
For your knee pain, continuing with physical therapy and using management techniques will be crucial. We may need to adjust your pain medications based on the results of today's tests and your kidney function. It's important that we manage your pain effectively without compromising your kidney health.
I appreciate that. I'll do my best to keep everything balanced and follow the regimen you set out.
Excellent. Let's meet again once we have the results from today's tests. We might need to meet sooner if there's anything urgent in the results. Remember to keep monitoring your blood pressure and report any significant changes.
Will do, Doctor. Thanks. Still appreciate your help navigating all these issues.
You're welcome. I'm here to help you through this, so don't hesitate to reach out if you have any concerns before our next appointment. Let's aim for a comprehensive approach to manage your health as effectively as possible.
Thank you, Doctor. I'll see you soon.
Extract 2, questions 13 to 24. For questions 13 to 24, complete the notes with a word or short phrase that you hear. You now have 30 seconds to look at the notes.
I've been feeling pretty rough these last couple of weeks, doctor. Started with this nagging back pain. Right side feels like it's pulsing. It gets worse if I move, but laying down seems to take the edge off. I've tried using a heating pad in icy hot, but it's just a temporary fix, and the icy hot sometimes burns a bit too.
I see. Can you describe the back pain a bit more? Does it spread anywhere else, or does it remain localized on the right side?
It mostly stays on the right, but it feels like it's moving around sometimes. Not really spreading, just shifting. It's hard to explain.
Understood. And you mentioned chest pains as well?
Yeah, that's been worrying me. They're sharp, like really sharp, but they come and go. Happens more if I'm moving around or trying to do something physical. It's brief, but it feels serious when it hits.
Have you noticed any patterns or specific triggers for these chest pains? Also, how's your breathing been lately?
Breathing's been tough too. I've got this ongoing cough, phlegm's been greenish, and it's been like this for a couple of weeks now. I've had bronchitis spells before, being a smoker and all.
Yes, your smoking certainly contributes to respiratory issues. How much are you smoking currently?
Still about half a pack a day. I know. I should quit. It's been the same since the 80s, though.
It's important, especially with your symptoms. And what about your medications? Are you taking everything as prescribed currently?
Mostly, yes. I'm on azithromycin now, got the albuterol for the cough, and some meds for blood pressure and cholesterol, though they halved the dose. Ran out of Metamucil, so constipation's back as well.
We'll need to address that too. Now, about the bullet you mentioned is still in your body from an injury years ago. Has it caused any recent issues?
Not that I know of, it's just there. Sometimes I wonder if it shifts and that's what causes the pain, but I guess that's not how it works.
Generally, if it hasn't caused issues before, It's unlikely to start now, but it's good to keep track of any changes in your symptoms. Now, regarding alcohol.
Cut down a lot over the years. Just a beer here and there, not like before.
That's good to hear. Moderation is key. Let's go over your latest test results to get a better idea of your current health status.
Please do. I want to understand what's going on.
Your blood pressure today is 142/88, which is a bit high. Heart rate is stable at 78 BPM, and your oxygen saturation is good at 96% on room air. Your blood tests show normal white cells and hemoglobin levels. Liver and kidney functions are within normal ranges, but we'll keep an eye on your creatinine since it's at the upper limit. Your chest X-ray and EKG showed no acute problems, which is reassuring.
So what's the plan then?
Given your symptoms and history, we'll continue the antibiotic treatment for your bronchitis. I recommend we also address your back and chest pain more actively. It might be helpful to adjust your pain management strategy if over-the-counter options aren't sufficient. I'd like to schedule you for a pulmonary function test and a stress test to assess your lung and heart health more thoroughly. Considering your smoking history and current symptoms, this is a prudent step.
Sounds like a plan. What about the smoking?
I strongly advise you to consider smoking cessation programs. We have resources that can help with that, and it would significantly benefit your health, especially your lungs.
I'll think about it, doctor.
Please do. It's important. Lastly, let's tackle the constipation. I'll prescribe a replacement for your Metamucil, and we need to ensure your diet is helping, not hindering this condition.
Okay, I can do that.
Great. Let's follow up in 6 weeks to reevaluate everything. If your symptoms worsen or if you have new concerns, please don't hesitate to come in earlier.
Will do. Thanks for going through all this. It's a lot, but I'm glad we have a plan now.
That is the end of Part A. Now look at Part B. Part B. In this part of the test, you'll hear 6 different extracts. In each extract, you'll hear people talking in a different healthcare setting. For questions 25 to 30, choose the answer A, B, or C, which fits best according to what you hear. You'll have time to read each question before you listen. Complete your answers as you listen. Now look at question 25.
Good morning, Mr. Thompson. How have you been managing since our last visit?
Hello. Not too well, unfortunately. My breathing has been worse, and I've been waking up at night feeling short of breath.
I'm sorry to hear that. Let's take a look at your medication regimen and see if adjustments are necessary. Are you still using the salbutamol inhaler we discussed?
Yes, I use it twice a day, but it's not helping much anymore, especially during the night.
It sounds like we might need to increase your dosage or consider an additional medication. I'll listen to your chest now. Have there been any other new symptoms? Any chest pain or increased wheezing?
No new symptoms, just the usual fatigue and some wheezing at night.
Okay, after the examination, we will go over your inhalation technique to ensure it's optimal. Managing asthma can be challenging, but I'm here to help you through it. Let's also discuss strategies for reducing triggers around your home. It's important that we address every factor contributing to your symptoms.
That sounds good. I appreciate your help.
Of course, Mr. Thompson. Let's also schedule a follow-up appointment to monitor your progress after these adjustments.
Now look at question 26.
Welcome everyone. Today I'm excited to share our upcoming public health campaign focused on increasing awareness about diabetes prevention. The incidence of diabetes has been rising, and our goal is to educate our community on how to prevent it.
That sounds great. What are some key elements of the campaign?
Thank you for your question. We're focusing on dietary education, regular physical activity, and regular screening for at-risk populations. We'll also distribute materials in multiple languages to reach a broader audience.
How can we as hospital staff get involved?
We're looking for volunteers to help with workshops and screenings. Your involvement would be invaluable in reaching out and making a real impact. Additionally, we plan to hold community events where we can engage directly with the public, offering screenings and live demonstrations on healthy cooking and lifestyle choices.
I'd like to help with the workshops. How can I sign up?
After this presentation, I'll distribute sign-up sheets, and you can choose the areas where you feel you can contribute the most. We're excited to have you on board. Together, we can make a significant difference in our community's health.
Now look at question 27.
I understand your concerns about Sarah's swallowing difficulties. One approach we can start with is modifying the texture of her food to make swallowing easier and safer for her.
What kind of food modifications are we talking about?
For starters, blending her meals into a smooth puree can help. It's important that the food is not only smooth, but also has the right thickness to prevent choking.
Does this mean she won't be able to enjoy normal foods anymore?
Not necessarily. As she progresses and we work through her therapy, we can introduce more textures gradually. It's about creating a safe environment for her to enjoy eating while strengthening her swallowing muscles. We will also use specific exercises to help improve her muscle coordination.
How long do you think this will take?
Every child is different, but with regular therapy and at-home practice, we could see improvements in a few months. It's important to be consistent and patient as these skills develop.
Thank you for explaining everything. We're committed to doing whatever it takes to help her.
That's great to hear. I'll prepare some materials and exercises for you to use at home. We'll meet weekly to monitor her progress and make any necessary adjustments.
Now look at question 28.
Today, I'll be discussing the importance of vaccinations for children, particularly focusing on the upcoming flu season. It's crucial that we educate parents effectively on why their children need these vaccines.
What specific points should we emphasize when talking to parents?
Great question. We should emphasize the safety and efficacy of vaccines, debunk common myths, and discuss the potential serious consequences of preventable diseases. Providing pamphlets and reliable online resources can also help.
How do we handle vaccine hesitancy among parents?
Listening is key. Understand their concerns, provide factual information, and be patient. It's about building trust and ensuring they feel supported in making informed decisions for their children's health. Additionally, explaining the science in simple terms can demystify how vaccines work and alleviate fears.
I've noticed that visual aids are particularly effective. Could we include more of those in our materials?
Absolutely. Visual aids like infographics and charts can make complex information more digestible. We'll include these in our next batch of educational materials. Also, having testimonials from other parents can be powerful.
Now look at question 29.
I see you've been prescribed a new inhaler. Let me show you how to use it correctly to ensure you get the full benefit. First, shake the inhaler well before each use.
Do I need to breathe out fully before I inhale the medication?
Exactly. Breathe out fully to empty your lungs, then put the mouthpiece in your mouth and press down on the inhaler while slowly breathing in. Hold your breath for about 10 seconds to allow the medication to settle in your lungs.
What if I cough after inhaling?
That's common when you're new to using an inhaler. Just rinse your mouth with water afterwards to help with the irritation. Remember, practice makes perfect. Do you feel comfortable trying a few practice sprays now?
Yes, I'd like to try it to make sure I'm doing it right.
Go ahead. Perfect. You're doing well. It's important to keep track of how many doses are left so you don't run out. Do you have any other questions on how to use it or about the medication in general?
No, I think that covers everything. Thank you for showing me how to do this correctly.
Now look at question 30.
Thank you for joining today's training on our new telehealth consultation guidelines. As we expand our services online, it's crucial that we maintain the same level of care as in-person visits.
What are the key components of these guidelines?
First, ensure your technology is working before the consultation. Privacy is paramount, so conduct sessions in a quiet, private space. Always confirm the patient's identity at the start of each call and document everything as usual.
Are there specific protocols for handling technical issues during a consultation?
Yes, have a backup plan such as a phone call. If technical issues can't be resolved quickly, reschedule the appointment. Our priority is the patient's experience and ensuring they receive the necessary care. We also need to ensure that all digital communications are secure to protect patient confidentiality.
That makes sense. How about follow-ups?
Follow-ups can be scheduled at the end of each consultation. It's important to make the process as smooth as possible for the patient. This includes providing clear instructions on how to connect for the follow-up and what to prepare beforehand. Making telehealth as user-friendly as possible will help us maximize its benefits.
That is the end of Part B. Now look at Part C. Part C. In this part of the test, you'll hear two different extracts. In each extract, you'll hear health professionals talking about aspects of their work. For questions 31 to 42, choose the answer A, B, or C, which fits best according to what you hear. Complete your answers as you listen. Now look at Extract 1.
Welcome to our in-depth healthcare talk. Today, we're diving deep into the complex world of community-acquired pneumonia, CAP, a significant health challenge globally. Pneumonia remains the leading infectious cause of death worldwide, a fact that underscores the necessity for nuanced understanding and approach to management. We'll explore various facets including diagnosis, treatment, and particularly focus on the use of biomarkers such as procalcitonin in clinical decision-making, supported by recent scholarly research from Harvard and other reputable sources. Let's begin with a case study that illustrates the complexities involved in diagnosing and treating CAP. We consider the scenario of a 76-year-old female patient, Mrs. Thompson, who was brought to the emergency department with symptoms suggestive of pneumonia. She had been experiencing increased lethargy, mild cough, and fluctuating temperatures over the past 3 days. Her medical history includes chronic obstructive pulmonary disease, COPD, and a previous hospitalization for pneumonia 2 years ago. Upon presentation, Mrs. Thompson's vital signs were concerning. She had a fever of 38.7 degrees Celsius, a respiratory rate of 22 breaths per minute, and her oxygen saturation was 89% on room air. Physical examination revealed decreased breath sounds in the lower lobes of both lungs. Initial blood tests showed elevated white blood cells, and a chest X-ray confirmed the presence of bilateral lower lobe infiltrates. The complexity of Mrs. Thompson's case is multifaceted. Given her age, underlying COPD, and acute presentation, the differential diagnosis is broad, including bacterial pneumonia, viral infections, or even exacerbations of her COPD. The challenge here is to identify the correct etiology to guide appropriate treatment. In terms of diagnostic approach, recent studies underscore the importance of utilizing biomarkers to refine the diagnosis of CAP. Procalcitonin, a biomarker that rises in response to bacterial infection, has been shown to be particularly useful. According to a study published in the Harvard Review, a low level of procalcitonin in the setting of pneumonia-like symptoms can help differentiate viral from bacterial causes. It is crucial in avoiding unnecessary antibiotic use and in promoting antimicrobial stewardship. For Mrs. Thompson, her procalcitonin level was measured at 0.1 nangram per milliliter, suggesting a low likelihood of bacterial infection. This pivotal information led us to consider viral pneumonia or a COPD exacerbation as more likely diagnoses. However, given her severe symptoms and potential for rapid deterioration, the decision was made to start empirical antibiotic therapy while awaiting further test results, including viral panels and additional markers of bacterial infection. Treatment strategies for CAP must also be tailored to the individual's clinical status and the likely pathogen. The current guidelines recommend a combination of antibiotics to cover both typical and atypical pathogens for patients with severe CAP like Mrs. Thompson. However, the choice of antibiotic can be narrowed down based on microbiological data as it becomes available. As we continue to monitor Mrs. Thompson, her condition began to stabilize with the empirical therapy. Further viral testing identified influenza A, which prompted us to initiate antiviral treatment. With the identification of a viral pathogen and considering her low procalcitonin levels, antibiotics were discontinued. This case highlights the dynamic nature of managing pneumonia, where initial broad treatment is refined as diagnostic information is gathered. This evolving approach is supported by a wealth of research indicating that tailored therapy not only improves outcomes, but also reduces the risk of antibiotic resistance. It's a prime example of how integrated care, guided by both clinical judgment and scientific evidence, is crucial in managing complex cases of pneumonia. Managing community-acquired pneumonia, especially in the elderly with comorbidities, requires a delicate balance of rapid empirical treatment and careful consideration of diagnostic and monitoring tools such as procalcitonin. By adhering to evidence-based protocols and remaining vigilant for the nuances of each patient's presentation, healthcare providers can optimize outcomes and mitigate the global burden of this potentially deadly infection.
Now look at Extract 2. Extract 2, questions 37 to 42. You now have 90 seconds to read questions 37 to 42.
Welcome everyone to our educational series on the complexities of managing sepsis in critically ill patients. Today, we'll delve deep into a pertinent case study involving fluid management and steroid use in sepsis, emphasizing evidence-based approaches and insights from recent clinical trials. Our patient, let's call him John, is a 63-year-old male with a history of diabetes and chronic obstructive pulmonary disease, COPD, who presented to the emergency department with symptoms suggestive of septic shock. He was hypotensive with a blood pressure of 8850 mmHg, tachycardic with a heart rate of 112 beats per minute, and febrile at 38.7 degrees Celsius. His initial labs showed elevated white blood cells, high serum lactate levels, and signs of acute kidney injury. In managing sepsis, one of the first considerations is fluid resuscitation, a fundamental component for restoring perfusion. The choice of fluid in sepsis management has been a subject of extensive research and debate. Traditionally, crystalloids like normal saline have been widely used. However, recent studies suggest that balanced solutions such as lactated ringers may have a renal protective effect compared to saline, particularly in reducing the incidence of acute kidney injury in septic patients. Let's consider the two pivotal studies from Vanderbilt, which were published in the New England Journal of Medicine. The first study, SALT-ED, and the second, SMART, both explored the impact of balanced crystalloids versus normal saline on kidney function and mortality in sepsis. SALT-ED showed that in non-critically ill patients hospitalized from the emergency department, there was a slight reduction in adverse kidney events with balanced solutions. SMART, on the other hand, focused on critically ill patients and found a small yet statistically significant decrease in the composite outcome of death, new renal replacement therapy, or persistent renal dysfunction with the use of balanced crystalloids. In John's case, considering his underlying acute kidney injury and the results of these studies, lactated ringers was chosen for initial fluid resuscitation. Within the first 24 hours, John received 3 liters of lactated ringers, following which his mean arterial pressure improved and lactate levels began to normalize. Another complex decision in managing sepsis revolves around the use of corticosteroids. The rationale for using steroids in sepsis is to modulate the immune response, which is often disproportionately inflammatory relative to the inciting infectious trigger. Historically, the evidence has been mixed, with earlier studies, like the French-led Corticus and Adrenal, showing no mortality benefit from steroids in sepsis. However, the French Approaches trial suggested a mortality benefit in certain severely ill populations. For John, the decision to initiate steroids was influenced by his refractory hypotension despite adequate fluid resuscitation and vasopressor support. Hydrocortisone was started at a dose of 200 milligrams per day. Over the following days, there was a noticeable improvement in John's hemodynamic stability, and vasopressor requirements decreased. This case highlights the nuanced decision-making required in managing complex septic patients. Fluid choice and steroid use are not only guided by clinical guidelines, but must be tailored to individual patient characteristics and responses to treatment. Furthermore, these decisions should be continually reassigned based on ongoing clinical trials and emerging evidence. The management of sepsis is highly dynamic and requires a careful balance of fluid therapy and pharmacological interventions. As we have seen with John, individualizing patient care based on the latest research and clinical guidelines can significantly influence outcomes in sepsis treatment. Thank you for joining today's session, and I look forward to our next discussion on further complexities in critical care.